Well, today it is my true honor to have one of my best friends, Dr. Jorge Garacoa, here joining us in our channel. I personally asked Dr. Garacoa to help me with this topic. He's going to be talking about today, when should terminal dentition be considered? I know that the American Dental Association and the Academy of Periodontics have come up with statements in relationship to terminal dentition. Personally, I've seen this topic sometimes being abused in dentistry today, meaning that many cases that should have some other type of treatment are being considered too early, in my opinion, as terminal dentition. So I don't want to get into it because I want to allow Dr. Garacoa to come out and talk about all his experience with this topic. Jorge, thank you so much for being part of our channel today. And before we get started, if you can just kind of summarize a little bit of who you are and where you practice, and then you can get started with your topic.
Mario, thank you very much for the invitation. It's a true honor for me to be a part of your channel. You've been doing such a great job with every social media person that you have. Your projects. I've been a fan of yours for a very long time. I'm a subscriber on the channel, so I watch your videos, and it's just what you contribute to the scientific world is amazing. So thank you very much. I appreciate it. So a little bit about me. I'm a prosthodontist. I'm from Ecuador originally, and I came to this country. I live in the United States. I live in Florida. I've been here about 16 years. I came to the States to do my residency. I did 2 years of AAGD. After that, I did pros at the University of Iowa, where I got my master's and my certificate in prosthodontics. And after that, I spent about 6 years teaching for OHSU in Portland, Oregon. And then after, I think a little bit after COVID, that we decided to move to Florida, and I started my private practice, my own practice in the city of Plantation, which is a little west from Fort Lauderdale in Florida. So the topic that I have prepared for you is terminal dentition, and like you said, Mario, nowadays we hear a lot about this topic. Okay, we hear, and it's I think the term is very popular because now we're seeing this explosion of cases where we're doing all on fours, right and left, all on fours, all on six. Is a topic that is really hot right now. But I'm a prosthodontist. I've seen a lot of cases. I've seen the good cases, and I also seen the bad cases. And unfortunately, when I see those bad cases, I always think, could have we done a different option? What would happen if we have maybe chosen a different type of treatment for this patient? We'll be in a different situation. So I think it's very important to go through a few things so we can talk about the topic. So first, we can define what terminal dentition is. This term is defined by the glossary of prosthodontic terms that in the latest issue that came in 2022. If I'm not mistaken, before this issue, that this terminal dentition did not exist in the glossary of prosthodontic terms. They was just so it's a very interesting thing. So they define it as an intraoral condition where clinical assessment and diagnosis determine that it's impractical to retain, rehabilitate, and to treat the remaining teeth. Now, I ask the audience, impractical to who? To the patient or to the dentist? And for me, it brings a lot of questions in my mind. I think that if it's impractical to the dentist, that is not the right way to practice dentistry. You should not do what's easier for you because you have the skills or the ability, and you're you're kind of like steering the patient to that treatment because it's easier for you. That is not the way we should do medicine in general. That's not the way we should practice. So I think all the options should be considered. So there are two basic things that once we have it present in the patient, it's going to determine that the teeth are not restorable. If the teeth are affected by insufficient periodontal support or compromised dental structure, right? I think these are big categories why we should consider a dentition to be terminal, right? When we have a very advanced periodontal disease, or where most of the teeth are, the structure is compromised, okay? And in the course of our careers, you're gonna see a lot of patients, and you're gonna see different phases of this patients. You're gonna see patients that have a few teeth that are affected. You're gonna see patients that have more teeth than affected, and then you're gonna see patients that are already edentulous, right? So how do you decide? How do you decide, you know, should I save a few teeth and keep some and do something removable, something transitional, and wait until the patient is a little more mature to remove all the teeth, or can I keep some of the teeth? So I'm gonna just go over basically some articles of Mitrani. Mitrani, Ricardo Mitrani is the one that wrote, I think, the most articles about terminal dentition. All right, I think the first article came out in 2019, and he gave a few is an algorithm in a few categories to be able to recognize which patients should we edentulate or not. Okay, the big categories are periodontal damage, like I said, and structural damage. Then they also add a few more categories, like the number of distribution of remaining teeth. Is referring to, so if I have some teeth that are not affected by structural damage or periodontal damage, can I keep them? The other is the dental gingival aesthetics. And another factor that I like to add that is not present in the article and is not discussed anywhere is age. Age is one of the most important things I consider when I prescribe this type of treatment, okay? So let's go over those things. The first is periodontal damage, right? I think by looking at this patient and looking at the radiographic information, I don't think anybody will say, this is not a patient with terminal dentition, right? You see
Yep.
patients that have I'm sorry, I was just moving the screen. Patients that have stage 4 periodontitis, that have grade 2 mobility more than 2, that had advanced attachment loss at least until the half of the root, and they have occlusal dysfunction. For me, that is the key indicator for recognizing this patient. Patients that have mobility, once the mobility is present and they have occlusal interferences that are causing more mobility, and also maybe super eruption in the teeth where the occlusal plane is already compromised, that is the turning point for me. Okay, when perio is stable and you can control it, and you don't have that advanced situation, there I try to save the teeth. But when you have this type of periodontitis where occlusal plane is affected and you also have mobility, then I think sometimes most of the times there's just no return for those patients.
Yep. I mean, and it's very easy to see in this particular case that you're sharing, where this is obvious. I think that it's very
Yeah,
obvious, and it's not really a case that you have to. There's a lot of thought process behind it.
yeah, exactly. The other category is structural damage, right? And again, I don't think we were able to keep the upper teeth. You see that he pretty much, ground all those teeth all the way to the gingival levels, right? So patients that have, a lot of caries, patients that have existing restorations, patients that have, root canal posts and cores. Remember that, if you see a patient, if you're looking at the patient radiographs and you see a lot of posts and cores, you already know that the structure is compromised. You don't have to remove the crown to know. It gives you an idea that, okay, the structure has been compromised. That's why we have a lot of posts and cores, right? So patients that are going to require a lot of root canal treatments, and patients that have no ferrule, and we are able to recognize that patient. But that is more a clinical, observation versus a radiographic observation. You have to, remove the crown and assess the teeth, to be able to determine that. For me, it's more like a clinical thing than a radiographic thing.
Right.
And the number of distribution of teeth, what the article is suggesting is that you will need at least four good teeth. I mean, 4 sound periodontal and structural sound teeth. 4 teeth per arch, and they also have to be distributed in a balanced way. So 2 per side, right? If you have those 4 teeth, you know, especially canines, right? Canines with long roots and first molars, you're definitely able to do partial denture, to do other kinds of treatments. You know, I believe that if you have a patient that is open to use a partial denture, any removable device, there are so many things, there are, intracoronal attachments, extracoronal attachments, implants that can help your partial. There's so many things that we just don't use because we're not trained to do that. You're not used to do that, or sometimes you say, oh, a patient's don't want to have a denture. But if you explain to them, hey, in order for you to have a normal four, I will have to remove a lot of your bone that is present right now. It's something that you put in perspective. I think if they understand what does entail to be able to place those implants and do an all-on-4, they will understand. They will be more prone to other types of treatments. All right.
One thing that I want to say, I want to just make a quick comment here. I had a personal patient that I didn't treat surgically. I treated her prosthetically, but she had the surgery. She needed full mouth extraction, lower arch, and she had him done by a good friend of mine, very good surgeon. But she did not understand. She did not completely understand. Okay, what are the consequences? What happens once you extract the teeth? What happens once you place the implants? How is the post surgical days are going to be? Are you going to swell? Are you going to be in pain? How is this going to be work out? And after the surgery was done, I mean, I was there the day of surgery. My friend went ahead, did the surgery, placed the implants. We placed a temporary hybrid. We connected all the implants together, and during the whole procedure, 4 to 5 hours, she was great. We send her home. She comes back 15 days later, and she's very upset. Oh, I didn't expect this. I was swollen. She wasn't in pain, but she was all, she was bruised and this and that. And I'm like, don't you remember that we had a whole conversation about this and what this entitles? And that's critical because patients, they feel like, oh, I'm just going to get teeth. But what is going to happen? What are the consequences of all the procedures that are going to be done before you get your teeth? And I think
Yeah.
that sometimes we as dentists fall short in that type of explanations. Have you had any experience with that?
Absolutely, absolutely. We're more concerned about them understanding sometimes the financial responsibilities, the actual treat,
Exactly. Oh yeah,
right?
you're right there also. Yep.
Yeah, yeah. Okay. Let's move forward. The other one is aesthetics, dental gingival aesthetics, right? And these are the patients that have either a high smile line when they're showing a lot of teeth, or they have a low smile line where we can hide some stuff. All right. This category focuses more on what is the potential aesthetic risk that that patient poses for the treat. All right. I mean, look at this patient right here. The teeth that this patient has periodontal disease. Some of the teeth have over erupted, and they're not. You can see they're being hidden by the lip, right? They're being a little bit. They are not in the right position because of
Mhm.
what happened. Okay. Um, Another thing that we have to consider, Mario, is also the transition line. Okay, yeah, so this is the patient that I just show you right now. You can see the patient had periodontal disease and the teeth have moved, and I have invaded a little bit of the space of the lower teeth, and now we have that problem. Okay, um, the one thing that's important to understand is the transition line. All right, if you're gonna do, for example, we're gonna operate on this patient and we're gonna remove all those teeth. Look where the teeth are right now. Look, just try to imagine where those teeth are supposed to be and how much bone you have to reduce to get that patient to the right profile of teeth. You know, it's gonna be a massive surgery, a massive
Right.
bone removal. And is the patient prepared for that? Does the patient have the bone for you to do that? Okay, it's
Right.
it's very important. So if we are planning a patient like that, and you look at where the lip is, all right? So when I say transition line, I mean about that border between the actual residual ridge and where the implants are at. All right.
Right.
That line cannot be exposed, cannot be, be below the lip. It has to be inside the lip
So
because
it has to be hidden by the lip.
it has to be hidden by the lip because we will not be, if that is show us, it really doesn't look very nice, right?
Right, right, right.
So
Patient will be very unhappy.
patient will be very unhappy. So that's where the transition line is gonna be, and so it has to be, hidden under that lip, right? So
Okay.
it's just imagine that if we remove that bone, look at how much, look at the bone that we have. It's not much, all right?
Right.
So it's some things that we have to consider when we plan these cases. It's just we have to look at every single aspect. Um, this is one of the patients that I treated. Look at that, what she had. She had those implants placed, and you can see that she's not very happy about how this looks. You can see
Right.
she's showing a lot of the pink, and also she's showing some of the transition line. So this is a disaster, right?
Right.
This is how she looked before, and that's how she looked after. In this case in particular, we didn't have to remove the implants and place them again. Just by changing a few components and also, closing a little bit vertical dimension, we were able to hide that transition line, and she was very happy. Thank God, you know.
Beautiful, beautiful work. I mean, it's impressive, the outcome.
Yeah, I mean, she is one of those patients that she was treated somewhere else. She's very upset. She's very upset because she spent a lot of money and she spent a lot of time, and she's still not happy. So
Right.
I don't think there's a compromise because the implants, even though they were maybe they were not planned correctly, I was able to use them all, and just by a few things, a few changes, we were able to have a better result. And with that, she was very pleased. She was very happy. So sometimes you have to kind of pick your battles, right?
Right.
Yeah. So another thing that we have to consider, Mario, is, I mean, where are the teeth that are gonna end up, and the lip support that you need, okay? And this is especially crucial when you're doing one arch, when you're only doing an upper arch and you're not doing both arches, okay? So look at where the lower teeth are, right? And look at where that maxilla is. Look, look,
Wow. Yeah.
look how much you have to push the teeth in front to be
Hmm.
able to meet the lower teeth. Look at that. Look at how much it's
Right.
almost like a cantilever.
Huge cantilever effect. Right.
Yeah. So that is, it's not only mechanically, like in disadvantage for the prosthesis, it's also a hygiene concern. I mean,
Right.
imagine you have all that cantilever. It's almost impossible, even if you have a nice intaglio of the prosthesis. It's a nightmare to clean those things, right? So another thing that we have to consider is that we don't talk about it often, and the lip support that the patient needs. And all these things come from a diagnosis phase. All these things can be seen if you just diagnose the patient correctly.
And
Uh,
that again, for me, Jorge, has a lot to do with experience. I mean, I can tell just by listening to you talk that you have a lot of experience, and this is the crucial aspect. A lot of people are doing this because because oh, it's everybody's doing it, and it's very it's something that is like you said at the beginning. It's interesting in dentistry what's happening today with the capabilities of technology and what we're able to do with printing and all the milling and all the beautiful things that labs are able to do. But it all comes down to the basics of dentistry. And the basics of dentistry come down to diagnosis, even if you're going to do a class two.
Correct. Exactly. Now, what I saying in the beginning is what is impractical. Is it for you or for the patient? So
Exactly.
it's a very, I think it's a very important thing what you said. Just look at the basics. We're in the era where everything is technology, but the basics are not changing. The
The
art of treatment
principles are the
planning,
same.
yeah, the art of treatment planning and just diagnosing correctly and treating correctly, that hasn't changed. It's
Right.
being aided by technology, but the foundations are the same, you know? And the last factor to consider is age. And this is something that I personally take in consideration, right? Um, this is a patient that I treat, and I'm gonna show you. This might be a little controversial, right? You can see this patient is in his early 30s. Unfortunately, a lot of things happened in his life, and he was not very concerned about his dental hygiene, and he neglected his care for a very long time, right? So that's how he presented to the clinic, right? And that's how the radiograph is. You can see that a lot of his upper teeth are compromised. Okay, so I mean, what are the first things you do to this patient? Try to have a plaque control. You do all the because even if you do extractions, when we do extractions in a patient like this, I still like to debride, right? Even if you
Exactly.
consider to do extract all the teeth, you should debride his mouth first. You should clean and remove all the plaque, all the the gross chunks of food should be clean before you do the surgery. You should not take this patient directly to surgery, you know.
Exactly.
So that's you're gonna do that first. You're gonna do that anyway. So I do a perio exam. I take care of the periodontal first of the soft tissues, and then you do caries removal, right? And you see what's underneath, And this patient, unfortunately, we pretty much end up with the only thing that it was viable were the front teeth, and all the front teeth had pulp exposure. They all need root canal treatments. They all need some type of core to be restored. So after discussions and after months of treatment with the patient decide, well, we decide to pull the plug on the teeth and do the all-in-4. And it's one of those cases that I probably will always remember, because he's very young. But at this point, in that situation, we had to make a call with what we have, and we just decided that what he had, which pretty much were the only, because even the canines were gone. Even he probably will have only like 7 to 10. The four
Right.
teeth were remaining, and they were all still compromised. So,
Mhm.
we have to make a decision, and that's what we decided. But again, the idea of treating a young patient, I think what we have to remember is that this patient got 4 implants placed today, and he's in early 30s. What's going to happen in 20 years when he's 50? Hopefully those implants are going to be, I really hope that those implants are still there, that he will take care of the teeth and he will take care of the prosthesis and nothing happens. Uh, but you know how dentistry is, you know, things are going to happen. Things are going to happen. We have sometimes patients come with this idea is like, I want something that will last forever, or maybe they are being told that this lasts forever, and this is a huge lie, a huge.
Right.
I tell the patient, go to your orthopedic surgeon and ask them for a hip that's gonna, last your whole life. They're gonna laugh at you, just by asking this. Nothing in medicine will really last for your whole life, right?
And the other thing that you have to consider, Jorge, and I don't know what your thoughts are on this, but is that what brought this particular patient to the four implants? It
Exactly.
was lack of care and
Yeah.
whatever other problems behind it, right? So
Yeah.
how can we guarantee that in his personal life things are going to go so nice and well for the remainder 50 years of his life that nothing
Mhm.
is going to affect the remainder teeth and the implants that are in place? See, that's
Right.
really what we have to, and that's what I tell my patients. I
Mhm.
tell them, if you haven't been able to take care of your own God-given natural teeth, which are made to last forever,
Mhm.
nobody's is going to be able to guarantee that four implants and a hybrid are going to last forever.
Correct. Yeah, that's a great point. It's a great way to put it, for sure. Put a little bit of responsibility on them, right?
Exactly.
They can take care of the prosthesis. Yeah. So yeah, so definitely age is something that I can say. If you can, please try to delay treatment for this patient. You do caries control, you do crowns, you do, and anything you can do to delay treatment for this patient. Because again, in 20 years, maybe you have to change your implant. Now you don't have any more. Now you're doing, transnasal implants, you're doing transsinus, you're doing cyromatics, you're doing
Right.
a lot more stuff, down the road. So, or maybe The only option that you have is a denture. And unfortunately, the patient after having a fixed prosthesis, probably they will not be happy with that, full dent,
Right.
you know. So that's how he looked at before, and that's how he looked after the mirror low was done. And I don't work there anymore, and so I don't really know what happened to that patient for the final, you know. So this is the algorithm that is presented in Mitrane's article. If you haven't read the article, download it, go and check it out. I think it's a great reference. And this is the last. It's been a few that he published. This is the last one in 2024, which is just has a few changes, again it's considering structural damage, the periodontal damage, and then if you have some teeth that are restorable or some teeth that don't have any periodontal damage, you should consider the distribution, the aesthetics, and that kind of thing, right? So you can decide to extract or not. So now we kind of finish and we went over the article. We can go over a few cases, and I like to I would love to bring this case to your audience and kind of like go over them, one by one. All right. So
Sure.
we have a patient right here, and I think we're gonna see a few cases. I think this is also pretty straightforward, right, Mario? You think it's
Yes, sir.
straightforward, right?
Yeah,
Uh,
you can see what's going on.
you can see what's going on. It's very easy to see. This patient is A2 because he has controlled diabetes, but you can see the patient has a lot of, perio affected teeth, periodontist, stage 4. He also had a lot of non-restorative teeth. He had a couple of FPDs that they fell out, and he's also 59 years old, right? So if we go through our categories that we just learned, we know that, perio, he has for sure the conditions to be considered a patient with terminal dentition based on his perio. Structural damage also, he checks all the boxes to be structural damage. Uh, all his teeth are pretty much affected either with perio or structural damage, so there's no remaining teeth that are untouched. The aesthetics, well, the teeth are damaged, but it's not a crazy, it's not crazy precision where they are, right? So aesthetics, you can play with that. In age, where do you draw the line? I will say, I'm 43. I mean, I'm not super young either, right? But I say, well, patients 59 years old, we can consider other options that are, consider extracting the patient's teeth, right? So
Right.
for this patient, we fabricated two prostheses, upper and lower prostheses, and he was able to have an upper and lower on4. I think, Mario, for patients like this, that are in this type of condition, and they're able to, turn around things and clean, I think it's a great option for them. It gives them quality of life. It gives them ability to chew, to enjoy their foods, enjoy their meals. And if they are maintained, if they're seen in your office every 6 months, every year, and you're able to maintain those implants, remove the prosthesis, clean the prosthesis, I think it's a life-changing procedure for some of the patients that really need it. So the option is there, and the treatment is great when it fits the right candidate.
Right. So when the criteria is followed, let me ask you something, Jorge, because you just mentioned it. So you do recommend removing the prosthesis at least once a year to get it cleaned underneath?
It's a great question, and I get it all the time. I think it's doesn't apply to every patient. If it I have patients that do such a great job with the water pick and the super floss, and they keep everything so neat that I don't really think that it's necessary to take it out, every year. Um, Sometimes when they have a very good hygiene, I don't take it out really. But when I see, but how many patients do you have like that? They're like that,
Right. No, no, 100%.
you
Now
know?
I do have to give you, I have a couple of patients in my office with hybrids, and the majority of them are really, really good with what they do. Give me
Mm,
just a minute. I'm sorry for that. Give me just a
that's okay.
minute.
No
They're
problem.
really good at what they do,
Mm,
and they're good at what they do because let me go ahead and so they're good at what they do because they've already gone through the whole process. They
Yeah,
want to make sure that it goes well. They want to make sure that they can take care of everything that they just all the investment time and money that they put in their mouth. That's what I find. Now, of
right.
course, my practice is not a practice, specifically on this type of dentistry, so I don't see the amount of patients that you see or
Correct.
other persons, other dentists see. But I also
Mhm.
know just with regular teeth, patients that don't take good care of them, and then we have to be, they have to come either, every 3 months instead of every 6 months, and we have to be a little bit more on top of them to make sure that they take care of their teeth. They take care of they do a good hygiene.
Correct, correct. I think it's very patient specific, you know. I do have some patients that do a great job, and there's no need to remove it. There are some patients that we plan this procedure, you know, we plan it and we remove it every year or every 6 months, you know. The ones that have 6 months, typically there's a reason behind that, right? And what we do is, you know, we create a protocol where, you know, we don't see all the access, we put something temporary that you can, you know, easily take it out. You know, that I think those patients that have a more strict, you know, hygiene protocol, they are in certain program. We try to use other things, you know, certain rinses, and we really kind of work on the training and on how to use the water pick, how to use the super floss, how do you use all these tools to keep your investment going, right?
Right.
That's
Because
why.
my understanding is that if you remove the prosthesis, you're removing all the multi-unit screws. You're gonna have to the multi-unit abutments are in place, but you just remove the screws to get the prosthesis out. You
Correct.
have to replace those screws. You can't use the same screws and retorque them again. Is that correct?
I mean, that's another interesting question, Mario, to tell you the truth. Um, we I personally change them, you know. I personally, if part of the service of the patient of, you know, removing the prosthesis and cleaning is also new screws, right?
Right.
I- you know, that you should offer that. Do you have to do that for all cases? I mean, do you have to do as a protocol? I do it because I like it, because I want to offer the patient a value what they pay. You know,
Right.
it's not gonna be, you know, the price for the maintenance is separate for what they pay, right?
Exactly. Exactly.
You charge for that, you charge for your time, you charge for the materials. I like to do it because, but you know, I don't think there's a protocol where you have to change all the screws, right?
Okay. Okay.
But
Well, my concern was always that once you torque the screw, the screw is fatigued.
uh,
So that's my fear. You fatigue the screw, the metal is fatigued. You go back, you torque it again. If
mm,
one of the little heads fractures, you're done. I mean, getting the little screw out of the multi-unit is not easy either. So that was just my concern.
yeah. But it's also, you know, once you remove there's some situations where you have screws that are loose and you will never be able to tell. You know,
Right, right.
sometimes, you know, it's sometimes I see patients that um, we will see bone loss around the implant, and it's because the components were not tight. Something got loose, and unfortunately, that caused, you know, movement, and that caused movement that we were not seeing, and you cannot
Uh-huh.
see that with the prosthesis on. You know,
Exactly. I know. I know.
unfortunately, you won't see it until you see bone loss. So, you know,
Okay.
if you can prevent that by making sure the components are tightly sealed and everything is tightened, that's what I will do, you know?
Right.
So
Yeah, no, you're 100% right. Yep.
anything that I see that will be a red flag around, I'll take the prosthesis out and I'll just check, you know?
Right. Right. Okay. It's good to know.
Yeah. Okay, another case right here. Again, this one here is also kind of controversial. All right. You can see this patient is 47 years old, so you know she's still pretty young. But she's SA1, she's very healthy. But you can see that her teeth doesn't have any plaque. She has very
Mhm.
minimal plaque. You know, everywhere. She has, I would say, good oral hygiene. She keeps her teeth clean. But unfortunately, she has mobility in a lot of these teeth, mobility 3 to 1. Not all of them are affected, but most of them have mobility. She has, you know, severe bone loss. Yeah, loss of insertion, probably index from 5 to 10,
Wow.
and she has super option. You can see also like those teeth are not in the right. Those teeth were not in the way they're not in the same place they're supposed to be.
Right,
Okay.
they're flared is what they appear to be.
Exactly. Yeah, you got it, Mario. Because of you had that clinical eye. They're flare out, which is the typical sign of periodontitis, right? They're flare out because they have mobility, they start moving, and now they're in this position where they're not aesthetically pleasing. All right. You can see
Mhm.
there's a lot of bone loss on this young patient. All right. Um, so like you said, they're flare out. So is this terminal dentition or not? All right. Uh,
Right,
so let's look at some of the factors. She has perio. She has perio stage 4, and most of
right.
uh she have all the teeth are there. Most of the structures, I mean maybe I don't think she even has a one restoration in her mouth. Not even one
Wow.
deposit, you know. Uh all her teeth are affected. There's no I all of them are affected by some degree of perio. The aesthetics is, teeth
It's
have
not there, right?
on there. And the age, she is 49 years old, so I would say she's still pretty young. All right.
Yeah.
Um, I don't have the final estimate for this patient, but this patient ended up with an all on 4. Okay. Or I think she had ended up with an all on 6.
On
But
the upper only the upper arch.
I think we're both arches, upper and lower.
Okay.
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 Unfortunately, the mobility was affecting most of the teeth, and there was just no way to stabilize the patient I mean, do you do occlusal adjustments for patients like this, Mario,
Yes, I do, but not. I have a periodontist that refers a lot of patients to me. Now, this is a little bit that what I wanted to talk to you about, because I don't think that, I mean, the cases that this case in particular, I don't see too much the controversy behind it on the decision, because I see that, when you review, clinically, you review and you're going through these steps and you're seeing that there's, out of the 5 X's, there's 3.
Uh-huh.
Out of the 5 check marks, there's 3 that are not good. Well, you have more than 75, you have more than 50% of issues going on. So I don't really see the controversy here, unless, now, again, I do have a periodontist that refers me patients for occlusal adjustment, because as you mentioned earlier, when you have
Mhm.
periodontal disease and your teeth move, you're going to have, you're going to get some occlusal interferences. Now, this therapy of occlusal adjustment is done at the same time that he's doing his periodontal surgery on the patient, and he's already determined that from a periodontal standpoint, if the patient goes through the treatment and then they follow up every 3 months with period maintenance, they have good prognosis. That's
Mhm.
literally what he writes down on the report that he sends me. He tells me, Mario, I have seen this patient, I have evaluated, the patient has been informed if he does this, this, and that, and then we have consistent follow-ups every 3 months, alternating with you and I, she or he should be in good shape. So he's already determined that he's going to be able to save the teeth. And you know what, Jorge? I have at least 10 or 15 of his patients that I help him maintain. And they are very, I mean, these patients have been stable for 20 years and they have the characteristics of periodontal disease, the sequelae, the recession, the large embrasures, the long teeth, but they are very well maintained and they have been maintained for 15 to 20 years. Now, I have one right now that recently lost 2 molars. After 15 or 20 years of periodontal maintenance, lost 2 molars. They just couldn't save them. They put 2 implants there, and I'm restoring those implants right now. But the remaining of his teeth are his natural teeth with periodontal sequelae of the treatment, but they're still there. They're not mobile anymore, and he is very, the patient is very good at maintaining that. So, in this particular case, was this patient evaluated by a periodontist? I mean, did the periodontist say this is not something that we can handle?
Yeah, correct, correct.
Okay.
She already had the consult with the periodontist. The periodontist saying that the teeth are hopeless. There's not much we can do. So,
Right. So that's really the bottom line. I mean, that's why we have all the specialties. And I feel that as long as you're consulting with the specialist and you give them your thoughts from a restorative side and they give you their thoughts from a periodontal stand, then the patient is really getting what is the best option for them at the moment.
mm, great, great. And let's move forward. All right, this is one of my current patients. This patient is 33 years old. He's also very healthy. You can see he has very poor oral health, right? And there's a lot of like rampant cavities and caries gingival and the gingival area. The patient has no mobility, no bone loss. Some of the products are a little deep because there's inflammation of the gums. Um, but he has no loss of BDO, and there are basically not a lot of changes in the occlusal plane. All right. So let's go over the category, right? And you can see the patient radiographs. For sure he has some restorations, root canals, but most of the teeth are there. And yes,
Mm-hmm.
a lot of cavities, but most of the teeth are there. So let's go over the criteria. Perio, good, right?
Good.
Good. No perio. Structure, good. Most of the teeth
Mhm.
are there.
Are in good shape, right?
Few of them have structural, changes, but most of the teeth are there. He has at least 4 teeth that are viable, untouched for sure. You know,
Yes.
techniques are, I think, there's of course things to do, but they're not in a good.
They're acceptable.
They're in a good place to start with, and he's pretty young, so it's very easy to say this patient is not a terminal dentition patient that you will remove all his teeth to do on for. You know, I
Mm-hmm.
think that even a lot of those patients will request this type of treatment of removing, just because, oh, I don't want to have multiple appointments with the dentist. I don't want to have endo. I don't want to have this. I don't want to have that. But they're just not understanding what they're asking. You
And they
know,
don't know what they're compromising to either.
exactly. Like we were just discussing, if they will know what the process is and what it entails and what will happen if some of those implants fail, I don't think nobody will really choose that option, knowing what
Exactly.
they know, right? Knowing what they know. So it's about patient education. It's 100% patient education. Okay. Yeah, he's another of my one of my patients too. And that's also a case I would love to discuss with you. So the patient is 65 years old. Patient is diabetic. She has poor oral hygiene, but she has no mobility, very little bone loss, no loss of insertion. Prone depths are 1 to 5. Some deep pockets, because of she has a lot of crowns, and some crowns are invading biological width. That's why
Okay.
probably she has that. But she has, her teeth are very short, not really having not lots of ADO, but you can see that the occlusal plane is a low canted. All right.
Mm-hmm.
She has multiple restorations with recurring caries. All right. So that's how she presents. You can see that she has a lot of, basically all her upper teeth are crowns, and some of FPDs, and they all have recurring caries. All right. One thing that I think is important to consider: what are the patient's goals? Okay. And another thing I like to ask: what is your goal? Besides removing the infection, removing the caries teeth, do you want to, is the tilted occlusal plane something that bothers you, something that you have noticed, something that you want to correct? Do you want to increase the size of your teeth? Do you think they're small? All those questions I asked, right? And this patient goals were also, she was also tired of seeing, small teeth, to see how canted her smile was. She was tired of seeing that for years and years and years. So, she also wanted to change that, right? You can see that pretty much every single crown that she had on the top have
Yeah.
recurring,
In
right?
recurrent decay.
Recurring carry, yeah. And some of them were not restorable, some of them were restorable. When we removed the crowns, we were able to see that it was very little structure left after the caries. So let's look at the patient's chart. Perio, she still has good perio.
Mm-hmm.
Structure, that's compromised structure. I think I missed that little X there. um she has, basically on the top, there's no teeth that is not compromised. All of them are compromised.
All right.
These are not very good, and the age, it's in a conservative age to do that. Okay. For this patient in particular, we decided to do implants and remove the teeth. Okay. She wanted to have all those changes And even if you keep those teeth and you do root canals for those teeth, and you have to do crown lengthening and just cut all those teeth out, right? And then even if they don't need root canals, most after you cut them all, most of them are going to need root canals, right? If you put them in the right spot, right? So, and for this particular patient, we were able to rearrange her occlusal plane, reposition the teeth by doing surgery, by removing the teeth, do some abuloplasty, and just rearranging the occlusal plane. And that's how she looks right now. That's how the immediate prosthesis look, and she's gonna come back, I think, next month to restore her upper arch. We're also going to do a full mouth rehabilitation on the lowers, of course, keeping the teeth, because there's a lot of good teeth in the bottom. There's no reason to remove those either.
I think that in this particular case, what I like about this case, Jorge, is that you've not only considered the chart, looking at perio, looking at teeth, looking at structural damage, looking at the things that you need to be looking at, but you've also considered the patient's wants. So
Yeah.
you had the patient's needs. You knew what you could do as a dentist, but you also consider her wants. And I think that when I look at this case I can see the end result, at least with the temporaries, how much improvement you were able to accomplish from an aesthetic standpoint, not even, of course, from a functional standpoint. Also, I think that merging all those things together was the right thing to do for this patient. So this is important because sometimes there's a lot of things in dentistry that we do that you go by the book, but sometimes you got to deviate by what the book says, and that's kind of what you've done. You checked your boxes, but you also listen to the patient, and that merge, that combination of things was to really what gave you what helped you decide which way you want to go. And I also, of course, applaud that you are saving the lower teeth. So you're really not being I think that this case has ended up you did on this case what this patient really needed.
Exactly, because by removing the teeth and rearranging the occlusal plane on the upper, I was able to make the changes that she wanted, and I can also replace lower teeth with restorations, with veneers, with new crowns, just in keeping the teeth right, because
Exactly.
most of the teeth are there.
And you created the space in order for you to do that.
Exactly, yeah. So this case is a little extreme. I'm still waiting for this patient to come back to do treatment, but I think for me it was I think it fits great in what we're discussing right now. This patient is 70 years old. He has also diabetes, high blood pressure. He has minimal plaque. He has no mobility on his teeth, and you can see he's gonna have a lot of recession. Has little bone loss. There is no loss of insertion, and his problem depths are 1 to 3 millimeters. He has loss of BDO, you can see it, but little changes to the occlusal plane, all right? And this is how he looks, okay? And if you remember the smile picture, you cannot see his
Upper lip, yeah, your upper teeth. I'm sorry. Yep.
cannot see his upper lips, his upper teeth. So let me move forward. So even though that there is some structural damage, right? There's some structural damage. There's still some tooth left. And like I said,
Yeah.
if you open his vertical dimension and he's not showing teeth, you can still use those teeth, So for me, when I see a case like this where I don't have any perio, and then I have the opportunity to open the video and also just rearrange the occlusal plane by showing more teeth. And if I have a good foundation of the tooth, even though that is compromised like this, nowadays we have so many good techniques, that don't require a lot of even preparation, a lot of good materials that can bond to teeth. So in a case like this, I will definitely consider, keeping the teeth. There are some situations you can also do crown lengthening, but I don't really think in this case, if you're gonna open that video, you don't really even need it.
Right. You need to show more teeth. This guy needs to show more
No,
teeth. You
exactly.
actually need to bring him down more, right?
Exactly. So there's a lot of possibilities if the patient is up for it, and you want to consider keeping the teeth. That's what you should do. In a case like, even though it looks that with a lot of structural damage, but I think the opportunities really to keep the teeth are there if you plan it correctly and you do it in a methodical way, right? And yeah, okay. So let's finish up with a few conclusions about the lecture. Um, First, I think we have to consider all the factors, the period, the structure, the age, everything that we discussed to make a decision before actually removing all the teeth. You have to go through the exact same thing we went through today. That will tell you if you check all the boxes, if you tell a patient it's terminal dentition or not. I think that algorithm of the article is a tremendous help. So you'll be able to make that decision.
And
The-
also, it's helpful because it also gives you the support if ever needed. If the patient ever comes back as saying, "Why did you extract all my teeth?"
Exactly. Exactly. I think that's a great thing. Um, the decision must be patient centered. Like I said, you also want to ask the patient, so what are your goals with the treatment, right? And that's what I meant with has to be patient centered. You need to understand the patient's goal and you are able to fulfill those goals. Now, that doesn't mean that if the patient has good teeth and they don't fit the algorithm to extract their teeth, you're gonna extract all the teeth just because they want to. That's not what I meant. What I mean. Um, and again, try to think about what's going to happen in 5, 10, 20 years. If patient is very young, somebody else is going to treat this patient down the road, and you need to leave structure so that the next person can treat that patient in 20 years. So I think that's a very important thing.
Exactly.
And with that, Mario, I want to thank you very much for your time, for your followers. If they have any questions, they can shoot me an email or just look me up on Instagram or X or Facebook. They can just look for my name or the office name, and I'll be happy to answer any questions.
No, and I also want to thank you, Jorge. And many of the people that are watching us today don't know the friendship and the story behind you and I want you to know that I feel very proud today of having the opportunity of talking to you and see for myself, the dentist that you have become. I know you for many, many years. You're a lot younger than I am. We started this journey. Your journey started with you and I together. I'm very happy to see what you're doing today in your own practice. I know that you continue teaching and you continue doing your things out in the community also. And I really really appreciate your time. And I just want to congratulate excellent presentation, and honored really to have you here in my channel. Hopefully this is not going to be the last time. It'll just be we will just say today till the next time. Thank you so much for your time.
My pleasure, Mario.